pop over. It takes about 30 seconds to initiate that stream. Oh, lovely. I see people already waiting and joining the room quickly. We love to see that. Let's not keep them waiting. Hello, everyone. Welcome back to Luncheon with the Experts at Carcinoid Cancer Foundation and Neuroendocrine Cancer Foundation. We appreciate you being here as always. My name is Rain Bennett. I'm your host. I am a filmmaker and a writer by trade, and I've been working with CCF and now NCF for years. CCF and I first established a relationship, and I want to say 2011, 2012, and over that decade plus, we have created, I don't know how many videos, hundreds of videos, maybe more, patient-centric documentaries, Q&A sessions, webinars like this, treatment-based videos, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. Now, if you are new to this journey or new to the show, I'd like to say hello. I'd like to welcome you. And the value that I really see pretty clearly in this show is twofold. One, the information and hopefully answers to some of your questions that you'll get from our guest presenter, as well as the shared support, the shared experiences and stories from within the community. So if you see the chat box, you see people signing on saying hello, I encourage you to do the same thing. Tell us where you're signing on from around the world. We'd love to see how far these programs reach. Inevitably, we have people up different parts of the world, way past their bedtime, still tuning in. So that's a good sign that excites me every time. But embrace the community. I assure you they will embrace you back. It's something very powerful and profound that I've been able to witness working alongside the overall net community for all of these years. Now, a couple of announcements. I mentioned this last episode. I just want to mention it again. We've had a post from CCF a couple weeks ago about what the future holds, and we had a lot of concerned messages from that. So I just wanted to say that again, CCF is just taking a brief step back, so to speak, to assess how they can continue to contribute to the overall net community in the best and most effective ways. So the show is continuing to go on. I know that we are at least booked up until midsummer and beyond, and the plan is to keep going for the remainder of this year and hopefully beyond that. So no worries there. However, if you do have any questions, you can always reach out to ncf. What is the new URL? Put it in the links for me because I'm still used to saying LACNets for so long. It is now the Neuroendocrine Cancer Foundation support line, ncf.net/support line. We can always answer your questions there for any caregivers, supports, patients, anybody who has questions about nets. Okay, let's get to today's show. We are excited to welcome back to the show for I don't even know how many times he's been here now. Dr. James Howe, welcome back to Luncheon with the Experts.
Hey, guys.
Appreciate you being here as always. We met and worked together. I want to say it was pre-pandemic times. I came out there to visit you, and you've been on the show a few times. If someone is not familiar with you and where you work and what you do, give us a little bit of bio and the role that you fill in this net community I alluded to.
Okay, well, I'm a surgical oncologist, so I do surgery on people with neuroendocrine tumors. I'm at the University of Iowa. I've been here for almost 30 years and was fortunate enough to be exposed to Tom and Sue Odorisio, and we built the clinic of neuroendocrine tumors here, and it's been active for several decades. Although both Tom and Sue have moved on, Joe Dillon, Yusuf Menda for nuclear medicine. Our medical oncologists have continued to carry on and taking care of, multidisciplinary care of carcinoid patients. Again, my role is to evaluate patients who might be candidates to have their small bowel neuroendocrine tumors or their pancreatic neuroendocrine tumors or their liver metastases be removed. And we see people who've already had surgery or who haven't had surgery, and our group kind of tries to give the best advice on where to go next with their next therapy.
Got it.
Did that answer the question, Rain?
Absolutely. Yeah.
All right.
100% answered it perfectly. Folks, a little bit of guidance and best practices for your questions today, which I encourage you to go ahead and start sending in now, because inevitably we get a little bit behind just catching up with the questions. So it's much better to start sending them in now rather than waiting to the last 5 minutes when you finally want to squeeze that question in. And the best manner or format to ask them is in small generic chunks. It's really hard in this format, this medium, to answer very case-specific questions or very super dense questions. If Dr. Howe feels like he needs some clarification about something, we'll ask. You can certainly chime back in. And there's no limit to how many questions you can ask. You can always ask follow-up questions, and I suggest you do. So think about it like a kind of a trail of breadcrumbs. What's the first domino that you need to get answered to fall down, and then we can keep going from there. So go ahead and start sending those in. I will start myself. I'm always interested, Dr. Howe, you and I were just talking about my upcoming potential hip surgery that I'm trying to prevent. And my surgeon was like, hey, my philosophy is if you can cope, I'd rather not put you under if you can avoid it. And I like that. I like a surgeon that's not immediately like, hey, yeah, let's get you in here, pal. In this space, sequencing comes up often, every week. And I know it's a big question, so I'm certainly not looking for a direct answer, but what is the thought process? What do you consider when it comes to sequencing when you're dealing with a NET patient?
Well, we tend to think that surgery is usually the first treatment because if you have a cancer, it's going to spread. So, if you can get to it early enough, you can prevent that spread. Unfortunately, a lot of people with neuroendocrine tumors already are presenting with metastatic disease. So then the question changes a little bit. Are you better off with surgery in that situation or some other kind of medical therapy or peptide radioreceptor therapy or embolization? So clearly, if somebody comes in with, say, a small bowel neuroendocrine tumor that's localized with maybe some mesenteric nodal involvement, or say you have a pancreatic neuroendocrine tumor that's localized, absolutely surgery is the first treatment for those. And it gets a little more complicated as the disease spreads.
Got it. Thank you. Got a couple of questions. We got plenty of people signing on from YouTube too, which I really like to see. We got a question. Oh, it looks like Wendy's on both channels. If you have tumors removed from the liver and pancreas, is it a given that they'll grow back? You said, often they will metastasize. And then the question is, are they perhaps faster? Are they slower growing? I know it's a very general or big question, broad question, vague question.
Well, I think the pancreas might not grow back. You
Okay.
might take that out, and then you may never develop another pancreatic tumor. You might, especially if you have MEN1 or some familial situation or VHL where you're likely to get multiple pancreas tumors in your lifetime. But if you're not one of those family members, the pancreatic tumor probably won't recur. But the liver metastasis is a more difficult thing because to get to the liver, it had to spread through the lymphatics or the portal vein up to the liver. And even if I take out, let's say you have 3 liver metastases, it's possible that you have a lot of smaller lesions that aren't seen on imaging, and those may eventually grow back. So if you look at large series where people have had cytoreduction of liver metastases, the recurrence rate is very high. It's about 95% at 5 years. So even though we can cytoreduce or debulk or get rid of most of the tumors in the liver, the vast majority of patients have other small tumors in the liver that we just don't see and can grow back. So it's not a given, but it's highly likely when you have metastatic disease that it will come back.
And another PNET question from Eileen. I think this is in reference to your first answer about sequencing. She says, even if PNET is less than 1 centimeter in the tail, would surgery?
Uh, should you do surgery? No, no. I think when it comes to PNETs, we like to think of them as really small ones, like less than 1 centimeter, whose propensity to spread somewhere is pretty low, on the order of just a few percent. So most of the time, if we know somebody has a 1 centimeter PNET or less, we'll just observe them. If it's over 2 centimeters, those numbers go up. The risk of nodal or liver metastases go up to over 20 to 30%. The hard thing to decide, the harder thing to decide is in the patients who have a 1 to 2 centimeter PNET, because there the risk of metastasis may be 10 to 20%. Pancreas surgery has more morbidity than, say, small bowel surgery and a lot of other surgeries. So the operations are a little more complex in terms of the recovery and the possibility of having a complication. So we really got to think hard about pancreas surgery in the people with the 1 to 2 centimeter PNETs. 1 centimeter, not so much. Just observe those, do an annual CT, see if it's getting bigger. As it grows bigger, you may want to do something about it. 2 centimeters in general will resect those. Now, the exception is if your tumor is making a hormone, which happens maybe 10 to 30% of the time. If it's making insulin or gastrin or VIP or glucagon, those cause syndromes that are pretty severe. And in that situation, a smaller tumor, you may elect to resect. A classic case is insulinoma, where even an 8 or 9 millimeter tumor may cause people to drop their blood sugars. They'll be driving on the highway and pass out and wake up in the median, or may run into the side of their house on the way home. Those tumors you might want to take out at a smaller size.
Got it. Thank you. Tanya says, hello, I've been recently diagnosed with NETs for the second time, stage 4 metastatic, having second debulking surgery next month and severe carcinoid syndrome. There's not really necessarily a question attached to that. So what should Tanya be concerned about, be focused on entering a second debulking surgery?
Well, I mean, it's always a little more challenging when you go back. The liver's been treated before. The liver will stick up to the diaphragm, and it takes a while to kind of dissect it off. Sometimes your access to the tumors is not as good as it was the first time. But there are a number of patients who have had a primary cytoreductive surgery and then over the many years have developed progression. They might have gotten PRRT or been treated with somatostatin analogs during that whole time, but things continue to progress. And at that point, I think there is an indication to do debulking surgery. But I would say of the patients that I operate on, it's probably the minority, probably less than 10+%. I actually see one of my patients is on this call who's had 2 debulking surgeries. And so there is a role for it, but it's not something you want to do every year or every couple of years. It's something you want to kind of reserve for after other treatments fail.
Is there any limit to how many times you might go back in?
Well,
I know that's
surgery's hard. People have incisions, it hurts. So, as patients get older, it's harder to tolerate. The adhesions and the damage to the liver from other therapies increases over time. So, I mean, I think there is a limit. I mean, I don't think I've done it more than 3 times in anybody. You probably could do it more than that, but again, surgery is harder to get over than most of our other treatments.
Got it. Thank you. Question from Ursula, our friend from South Africa. Hey, Ursula. Does increased liver function like alkaline phosphatase mean tumors are growing? My AST and ALT remain the same, slightly high. 9th round of PRRT in April 29th. My first 6 was in 2021, 22, but due to progression, I started again with PRRT in 2024.
Well, alkaline phosphatase is an enzyme that's in the liver. It's also in bone. And not the most sensitive to really kind of be specific for the liver. AST and ALT are pretty good to know what the liver cells look like, although you can have a lot of liver replacement and liver damage and those numbers still look normal. So those numbers are a general guide. When they're elevated, then that can be problematic. Anytime we treat the liver, they're going to be elevated at least transiently. But just looking at liver functions alone are not as not always that useful. I think the better guide is the percent of liver replacement, the distribution of the tumors, and so forth. The most important thing for liver function too is like knowing that you can make your clotting factors, and that's checked by prothrombin time or an INR. If you can make the clotting factors in your liver still functional, and your albumin level, which is a protein level in your blood, is another good indicator of general liver function. But again, your liver can be replaced with tumor a fair amount, and those numbers can still look normal.
Got it. Thank you. Next question from Janice. Janice says, I had 4 PRT treatments during clinical trials in 2017-18, 20 rounds last year for triple negative breast cancer. I'm having progression in the liver now. The question is, can I do PRT again?
Yeah, I mean, PRT, over time will hurt your bone marrow. Okay, so 4 cycles of PRT is what we would consider, one treatment. And most people can probably tolerate 2 cycles in their life, or two of those 4 rounds in their lifetime. However, if you say you got 20 rounds, I assume you're talking about chemotherapy. Again, that can injure the bone marrow as well.
Hmm.
So there's a low incidence of leukemia and myelodysplastic syndrome after PRT. It's about 2%. But that number may be higher in people whose bone marrow has been heavily pretreated with chemotherapy. So, can you get PRT again? Yeah, you might be able to get it, but you definitely want to work closely with your team and make sure there aren't other options. So, if the liver's progressing, there are other options like can't remember if Janice had a PNET or an SBNet. She didn't really specify, but let's assume it's an SBNet. Well, there's everolimus and cabozantinib. They're not, cabozantinib has just been approved, but those come with a price as well. There are side effects from that treatment. There's also embolization of the liver, and surgical cytoreduction is also an option. So, depending on what the mutation, or sorry, what the metastases look like within the liver, I think those should be considered. Another round of PRT, you got to think twice about it. I mean, I'm not saying it can't be done, but there's some risk.
Got it. Thanks, Janice. Appreciate your question. Let me know if you have a follow-up. Moving along, this is a good general question from Jim. If a patient wants to switch care from one cancer center to another, is it better to cut all ties with the original cancer center? And if not, what's the best way to maintain contact without the situation becoming awkward for your doctors?
Well, Jim, that's a great question. Yeah, I mean, it's hard as a patient to navigate, right? So everybody understands that it's really important. You have this one life, right? So you need to kind of seek out opinions and try to find people that you trust and that you're comfortable with, okay? And if that, if you see me and it's not me, well, I shouldn't have hard feelings about it, but if you still have ties with people that you respect, and their advice is helpful to you, you shouldn't necessarily cut all ties, because I can work with people from other institutions. If you have a medical oncologist at MD Anderson, I probably know that person. I can talk to them on the phone, or we can email each other about your care and kind of think, even though we're not at the same place, we can kind of put our heads together and think about the next best treatment for you. And so, there's a really good network amongst neuroendocrine tumor physicians, through NANETs especially, and through some of these groups like CCF and NCAN and HealingNet and other patient advocacy groups. So I don't think you should necessarily cut all ties, but if you feel uncomfortable and you think they're giving you a bum steer and it's clear that it's not that helpful, then you might want to do that. But that's a personal decision. I think if those people are local for you, you might not want to cut those ties, because it's possible that those people, even though they might not be making the main decisions about your care, they might be giving you the somatostatin analogs, and you might want to keep that person there, or if you're having trouble, to have somebody nearby who can see you without having to travel.
Got it. Thanks. Appreciate it, Jim. From Tanya, are stage 4 metastatic NETs in the uterus and ovaries uncommon?
So if you're talking about spread to the ovaries, that's kind of common. We see it fairly frequently in small bowel NETs. I would say it's uncommon in pancreas, but in small bowel, it's pretty common. The uterus can be a site where if the tumor grows through the wall of the small intestine, cells will just kind of spill off and land down in the pelvis and eventually grow. So it's not that uncommon to see some things on the uterus from that perspective. They can also end up in the ovary by the same mechanism, but they can also go in the bloodstream to the ovary. So it's not that uncommon to see it. Usually it's associated with what we call peritoneal disease, where there are multiple nodules in the abdominal cavity. And when you have surgery, it's important to try to, get rid of as many of those as you can, because sometimes they cause problems.
Got it. Thanks, Tanya. Question from Shane. Hey, Shane. How much does your practice and your net team at Iowa take into account genetic mutations within the tumor, i.e., DAX, ATRX, MEN1, etc.?
Well, I think, so the mutations that you just mentioned are important in pancreas neuroendocrine tumors, not really relevant that much in small bowel. So I think those can be helpful for determining prognosis. But, would we change therapy based on that? Not necessarily, although the exception would be for like fine needle aspirations of smaller PNETs where you're kind of on the fence about whether you're going to resect it or not. If there's an ATRX uh, mutation or DAX, and we don't usually do sequencing, we'll usually look by immunohistochemistry. But if it looks like those are lost, then it might push you to doing surgery in a situation instead of observation. But let's say it's a bigger PNET and we take it out, that's important information, but it may not necessarily change how you treat the patient. That'll be more based on the disease distribution and whether it's coming back or not.
Got it. Thanks, Shane. From Melissa, is surgery possible if they're with gastrinomas and no prime areas found, predominantly lymph tumor burden with small liver and bone mets? Did you follow that?
Yeah, I mean it's not an uncommon situation where you have a gastrin producing tumor and all you got to show for it is a big lymph node on a CAT scan or a PET scan. And I've been in that situation many times. And the first thing to do is really try to make sure you can't find something in the duodenum. And so we'll do an endoscopic ultrasound and have them look really carefully in the wall of the duodenum. A DOTA PET scan might help with that. And then intraoperatively, you can open up the duodenum and try to feel for a lesion, although that adds some risk to the procedure. There are some patients where I've just removed that solitary lymph node and not been able to find a primary, and those patients have done well for a long time. And it's frustrating because you know that there's probably a small tumor somewhere, but you just haven't found it. But the bulk of the disease and the gastrin levels are maybe coming from that 2 or 3 centimeter lymph node. So sometimes you just remove the lymph node, and that's the best you can do. Doing a blind Whipple procedure or some huge operation without identifying a primary tumor first, I think is probably inadvisable. You'd be better off just removing the lymph node in that situation.
Got it. Thank you. We had a question a moment ago about the how common metastases to the ovaries and uterus were. We have another from Mary Beth asking about bone mets. How common are bone metastases?
Well, they're more common than we used to think. Ever since we started doing DOTA PET scans, where you can see the bones throughout the body, which you don't see on a CAT scan or an MRI generally, unless it's a pretty big bone lesion, you're going to miss it. But since we've been getting DOTA PET scans, we notice that a lot of people do have bone metastases. And now the percentage, I'm trying to think. We just reviewed a series of small bowel neuroendocrine tumors, and I think it was maybe 10%. But it might be even higher than that. If you have liver metastases, I think that number goes up a fair amount as well. The good thing about, well, the thing about many bone metastases is they're small, and a lot of them don't really need specific treatment. But as they get larger, it puts the bone at risk for fracture. And if you're having pain in an area that there's a bone metastasis on a DOTA PET, Uh, or if there's concern about its size, sometimes they'll be treated by external beam radiation.
Hmm.
We don't usually go in and resect them. That's a little bit much, and radiation can often work pretty well. When you get PRT, that will also go to the bone mets that are seen on a DOTA PET scan. So that's another way we can treat bone metastases. And clearly, if you're getting somatostatin analogs, once a month, that those will also bind to receptors on bone metastasis and hopefully help to keep them from growing.
Bethany asks, does Iowa perform histotripsy? And what else might you be able to tell us about histotripsy? Always questions about this one.
Yeah, well, histotripsy is a new ultrasound technology where they can beam an ultrasound onto a liver lesion and try to kill it the way we would use ablation, say, in the past, where we put a probe in and heat something up and kill it by you know heating it up. Um, so histotripsy, we have not invested in the machine. It's kind of expensive. There
Hmm.
are many centers that are really interested in it. There are some limitations to histotripsy. I think it's good for somebody who has a small number of lesions. They have to be in a certain part of the liver to be accessible to histotripsy. Um, but a lot of patients that we see have 10 or 20 liver metastases, and going after one or two of those by histotripsy is not really a good strategy. But it is pretty good in somebody. Let's say I did cytoreduction on you 3 years ago, and you've got one or two tumors growing back, and it's in an accessible area. The nice thing is you don't need to have repeat surgery. You can have this histotripsy procedure performed without an incision, although a lot of times I think they do it under general anesthesia because it might hurt. But it's kind of expensive. We don't know what the long-term results are. I'm kind of waiting to see what those are before we would invest the several $1 million it would cost to buy the machine. So I'm waiting to see the results of other centers, and the results are very preliminary. And
Hmm.
so I know there's a lot of excitement in the patient community because who wants to have an incision and have to recover from surgery if you could have a non-invasive technique? But again, the short-term data is from a variety of tumors like hepatocellular cancer, some metastatic colorectal cancer literature. What we know for neuroendocrine tumors is not really mature yet, so that may take several years.
Got it. Thank you. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, a CCF and NCF program. Today we are here with Dr. James Howe from the University of Iowa. Great questions so far. We are moving along quickly. We're almost halfway done. So just a little more than half an hour left. We will continue on trying to get to all your questions. The next one comes from Shane again. Is there a specific area of the liver that's difficult to operate on? My mom's had 2 debulking surgeries, but both times stubborn dome tumors by the diaphragm had to be left behind.
Yeah, I mean, sometimes it can be hard to access them. It sort of depends on how you're approaching the liver. Like a lot of times I'm resecting the pancreas or the small bowel, and so I have to use an incision kind of in the middle of the abdomen as opposed to underneath the rib cage on the right side. And when you use the middle of the abdomen, sometimes some lesions over the top of the dome of the liver are hard to get to. Sometimes they're hard to ablate as well. So yeah, that can be harder. The hardest ones though are the ones that involve the major blood vessels and bile ducts that come into the liver. So if they're more uh, near the hilum of the liver, which means where they kind of branch off into the left and right branches, or if they're on a major right or left branch, then the treatment options become more limited. In order to get something like that out, you may have to take out that half of the liver rather than just enucleating it if it were more
Mm,
on the surface. And it's hard to ablate those areas because if you heat it up with a microwave, then you can burn the bile duct there. And
mm.
if you burn the bile duct, it can cause a stricture, and that means that half of the liver is not going to drain that well. So that area can be very problematic as well.
Got it. Thank you, Shane. Non-surgical question. Greg Jean says, how dangerous is a high serotonin level to general health?
Well, I'm assuming the serotonin is from a neuroendocrine tumor with metastases. So the to general health, I don't know about in general, but I know the biggest concern that I would have over time is that it causes problems with your heart valves on the right side of your heart.
Hmm.
So people get something called carcinoid heart disease, where the tricuspid and pulmonic valves on the right side of the heart get stiffened and they get insufficient. That is, that blood will kind of leak back into them, and that can cause heart failure. So that is probably one of the worst things about having high serotonin long term. Plus, there are the other issues like flushing and diarrhea and the symptoms of carcinoid syndrome. How bad is that for you? I mean, the serotonin, again, is bad for the heart valves. Just having those symptoms is bad for you. Having a lot of diarrhea, for example, can make you dehydrated, and that cannot, that can be bad for your other organs, perfusions, and so forth. So, those are the biggest things I worry about. I don't really worry about structural damage to other organs like the kidney from the high serotonin unless you get dehydrated from diarrhea or something like that, or from the heart failure.
From Tara, do GLP-1 medications have any effect on nets?
Well, that's a good question. The receptor for GLP-1 and something called GIP are called incretins, and that's what are being treated with these new diabetes and weight loss drugs. So, Ozempic goes to GLP-1 receptor, tirzepatide goes to GLP-1 receptor and GIP receptors. We're currently studying this actively in our lab, and most neuroendocrine tumors of the small bowel and pancreas will express the GIP receptor. So there's some questions about tirzepatide because it'll bind to that, and we've shown in cell lines that when you are on when we treat a cell line, this is in the lab, okay, this isn't in a person, but if you have a neuroendocrine cell that has these receptors, that it might increase their growth. Now, I don't want to panic everybody because, and we recently published a paper on this. It's in the journal Surgery from this past year. But for GLP-1, a lot of small bowel tumors, we do, Dr. Ear in my lab and Andrew Belizzi, our pathologist here, they've just completed doing immunohistochemistry studies, and a lot of small bowel nets don't express GLP-1. That seems to be common GLP-1 receptor. That seems to be common to adrenal tumors, maybe a little bit in pancreatic tumors. So it may be that those particular agents might be safer than the tirzepatide, but this is what we hope to study over the next several years, and our data is very preliminary. These drugs are out there; lots of people are on them, and we're not quite ready to give advice that people should stop those medications because it may be that GLP-1R is not expressed that much on neuroendocrine tumors, but we need to do further work on this.
Got it. Thank you. Thank you. From Melinda, I have MEN4, small cyst on the pancreas tail, which is being watched with no change. My main question is how often should I have a colonoscopy and endoscopy? I also have lung nets.
Okay. Yeah, that's a pretty rare syndrome. So I'm not. I gotta say, I'm blanking on the need for colonoscopy and endoscopy in that condition.
Yeah.
So I'm gonna have to
Um,
pass.
okay. And Melinda, let me know if you have any other clarification that might be helpful to for us with your question. And we'll try to get back to that. Moving forward, Elaine says, stage 4, having progression after PRT in liver and lymph nodes, increased diarrhea and flushing. Options are alpha trial, doing beta again, or liver directed. I have severe osteoporosis and I've had spinal fusion surgery. What might be the best option, or at least what should she consider further? Thanks, Elaine.
Yeah. Well, you need to understand that the alpha agents are still in clinical trials. Okay, so that means that they haven't been tested as much as we need for full FDA approval. And, that just came with Lutathera back in 2018. And that was after 20 years of using that in Europe. Um, so radiation, can have damaging side effects. And, those side effects may result, say, in alpha therapy and improve killing of tumors. But the real question that hasn't been answered, at least from my standpoint, is, what's the kidney effects of these alpha agents? Because, I think there is some evidence that, you know, damage to the kidneys may be occurring more with the alpha than the beta agents. So, if I think those trials are really important to complete, and if you're eligible for an alpha trial, you could think about it. The osteoporosis, I'm not sure how that's going to really affect the alpha versus the beta, but I'd be more worried about the kidney effects. Um, and so, and you say doing beta again, so you've already had
Hmm.
beta. Okay, and then one of the alpha trial is for previously treated patients. So you could look into your eligibility for that. But again, remember it's a trial and they're still assessing the safety. Getting Lutathera again would be okay as long as your kidney functions okay and your bone marrow looks okay. So, that's a difficult thing to answer specifically, but you need to be looking at it from those different perspectives.
Thank you. I appreciate your question, Elaine. Let me know if you have another one, a follow up one. From Heather, what's your opinion on continuing lanreotide despite being no evidence of disease for 5 years? And Heather has PNETs with metastases to the ovary.
Okay. Well, I mean, I think if nothing's showing up in 5 years, you can do what we call a somatostatin analog holiday. You can come off it for a while and, make sure you're still being screened for the metastases and see what happens. If your subsequent scans in the next 6 to 12 months don't show any new tumors, then it may be a very reasonable strategy. As we know, these drugs are expensive. They have some mild side effects. Fortunately, they're pretty well tolerated, and people can be on them for decades. But there are patients who have no evidence of disease who are on it initially for metastatic disease and nothing's showing up. And I think it's quite reasonable to try stopping them and just to seeing what happens.
Got it. Hey, thanks, Heather. From Wendy, large tumors on pancreas and liver are responding well to embolization and lanreotide, and my lifestyle is pretty good. Is it okay to hold off on surgery till tumors start growing again, or is that just delaying the inevitable?
Um, well, embolization isn't often done to the pancreas, so I'm not really sure if you're probably talking about the liver for that, and maybe the lanreotide is holding the pancreas in check. And if it's really big and hard to resect, and depending on what your liver distribution is, if there are lots of liver mets, then you want to keep doing what you're doing. The other thing you really want to consider in that situation, if it's an advanced pancreas tumor, is the combination of capecitabine and temozolomide, because about half the tumors will respond to that, and it can really shrink those tumors up and make them more resectable. We have lots of patients who I see who have really bad liver disease and really large pancreas tumors who will be treated for 6 to 12 months with Captem, and they'll have good shrinkage. And all of a sudden, after that time period, I can do something pretty effective surgically. So, is surgery inevitable? No. I mean, you can choose not to have surgery, and especially in the elderly or people who have a lot of comorbidities where surgery might be dangerous to them, maybe you're better off with that strategy. But if you're relatively young and in good shape and surgical resection is an option, we tend to think that that's, the preferred option in terms of getting out the primary tumor that might continue to metastasize and then trying to reduce the number of metastases in the liver to set back the clock so that, you won't get liver replacement where it'll stop functioning at some point, to a later date. So it's a complex question. I hope
Yeah.
I the components that will help steer you to the right answer.
Thanks, Wendy. Let me know if you do have a follow-up question. Next one comes from Gene. If you had a stem cell transplant that was autologous to, are you at a higher risk if you have PRRT?
Jeez, that's a good question. I'm not sure if I know the answer, but I would guess you would be at higher risk. I imagine your bone marrow reserve is not as good, but I'm not a bone transplant person, and so my knowledge of, whether they get full recovery of their bone marrow is minimal. So I would guess that you would always be at a little bit higher risk because even though you got your own stem cells back, have they repopulated 100% to where you were before, or is it just 30%? That's something I don't know about the long-term patients with bone marrow transplant.
Got it. Thanks, Gene. Next question from Sasheen. Sasheen says, "Hi, I just received second surgical consult, and he is proposing two-stage debulking / resections, citing concerns that a single procedure would leave too little healthy liver left. The doctor would resect small bowel and mesenteric mets and left lobe masses first, allowing regeneration, then remove the right lobe. Carcinoid syndrome has been difficult to control, so he's trying to debulk as much as possible. What are your thoughts? My surgeon does have net expertise. My only concern is scarring causing issues with the second surgery."
Yeah. Well, sometimes, Susheen, the situation is complicated where you need to do a two-stage operation, where taking a lot of liver might put you at risk for liver failure. And so in that situation, doing a two-stage procedure may make sense. Doing the small bowel resection of the mesenteric mets, taking out the left lobe masses, looking for regeneration, then doing a right lobectomy. I mean, yeah, I think there are definitely circumstances where that might be a good approach. So, without looking at the CAT scan, I don't want to second guess, but if it's an experienced neuroendocrine tumor surgeon, then that sounds like, it might be a reasonable approach.
Thanks, Asheen. Good to see your name pop up. Susan says, "Do you recommend a dotatate scan for newly diagnosed PNET that is less than 1 centimeter?"
Yeah, that's a good question, Susan. I think that the risk of metastasis, and that's the main value, I think, of the DOTA is to see if it's spread to the lymph nodes or elsewhere. Um, I think the risk of that is pretty low with a 1 centimeter tumor, and I think it's not really that important because a lot of those were just going to be observed anyway. Um, so, for peace of mind, maybe you could do that to kind of help prove that there's no lymph node metastases or liver metastases. I think that would be the biggest role. But the real question would be, would insurance pay for it or not? Because that could be an issue.
What's your current practice for managing carcinoid crisis during surgery? And does this differ between functioning and non-functioning tumors?
Well, it usually happens with small bowel neuroendocrine tumors. It's kind of rare in PNETs. So the current thinking, and Rod Pommier in Oregon has done great work on this. He has some really important studies that looked at this very carefully. And, the standard was to give an octreotide drip to try to protect against the effects of serotonin that we presume were causing these hormonal changes that would cause the blood pressure to drop and the heart rate to drop and doing weird things intraoperatively. But Rod's careful studies show that these occurrences during surgery weren't really related to high hormone levels. And it became clear as he treated patients without octreotide drips that the most important thing was to give them vasopressors and fluid to bring the blood pressure up. And he found that when they did things that way, that patients would have a lower period of low blood pressure, which leads to better outcomes. So I still use an octreotide drip in patients with high serotonin levels, even though I totally believe everything Rod's done. And I think he has stopped using octreotide. But, in a lot of places we'll still use an octreotide drip, but the anesthesiologist needs to know the blood pressure gets low. Giving blood pressure raising medicines and fluid is really the first treatment, and that needs to be instituted right away.
From Sarah, can cortisone injections for arthritis cause issues with tumors in the liver or growth of them, since the cortisone may mimic hormones?
Hmm. Yeah, I would think that the cortisone injections into joints would be more localized. Even if you were taking hydrocortisone by mouth or by vein, I don't know that the hormone cortisone is going to or cortisol is going to cause growth of tumors. I don't think there's any evidence of that.
Thanks, Sarah. From Bethany, do you still perform labs for pancreastatin, chromogranin A, neurokinin, 5-HIA, and how often? And then follow up, are labs sent to ISI?
Yeah, we still follow pancreastatin, chromogranin, and serotonin in our patients with small bowel nets and pancreas as well. Neurokinin A will often get early on for prognostic reasons. We don't use 5-HIA a lot here, but I think it is a very good test. And do we send them to ISI? I don't know if they all go to ISI. Um, Pancreastatin and 5-HIA do, but I'm not sure about chromogranin and serotonin.
Got it. Thank you. Dun, dun, dun. Guys, we have just a little bit more than 10 minutes. Moving along. Dun, dun, dun. Question from Melinda. I had a net tumor that was small on my duodenum 2 years ago. I'm not sure how often this should be watched with endoscopy. It was removed, but it concerns me that the area needs to be watched more often than every 2 years, as the gastro doc recommends. He is not a net specialist. What are your thoughts, Dr. Howe?
Yeah, I mean, when you have a tumor in your duodenum removed endoscopically, I mean, it's hard to get a full thickness of the bowel wall because if you do, by definition, you put a hole in it, and that requires emergency surgery to fix. So it is hard to get the full depth of the tumor, and so there is a risk of recurrence of those endoscopically removed tumors. And so I think, doing it every year, at least for the first couple of years, makes sense. But if nothing's growing back, then I think you can spread it out to 2 years. And again, we did a study where we looked at endoscopic removal versus surgical removal. And I think endoscopic removal is very acceptable for these tumors, but you do need surveillance like you're asking about. And usually we'll do it, every year for the first few years. And then if nothing's coming back, then go out to, maybe every couple of years.
Comment, not a question, from Bridget. I just want to say hello to my favorite doctor. I'm at work, so I'll rewatch later. Please tell him to keep up the good work. So, Dr. Howe, keep up the good work. Thank you so much. Appreciate you chiming in. From Nancy, and I've seen this question before. Have you ever heard of someone gaining weight after taking lanreotide? I've stabilized at plus 30 pounds after starting injections, and I'd just like to know if you've ever seen that type of weight gain before.
Well, so lanreotide can mess with other hormones. So it can mess with thyroid hormone, can mess with insulin. So, I think it's possible that, people become hypothyroid because they're on lanreotide, and that itself can cause weight gain. I don't know if the lanreotide itself, causes weight gain because you eat more or less. I don't think it does that, but certainly the mechanism from hypothyroidism might be one. So it'd be important to get your thyroid levels checked because there are a number of patients on that medication who need thyroid replacement, and that will definitely cause you to gain weight. There may be other mechanisms, but I'm not sure what they would be.
Got it. Thank you. Thank you. From Ange, I have a 1.4 by 1.1 centimeter tumor in the head of the pancreas. Scans show that the tumor has been there since 2018, and I was not informed. I had a biopsy, and the sample was not conclusive. I'm booked for a triotide scan. The question is, should I do the biopsy again? The surgeon thinks that the GI doctor may not have gotten the sample from the tumor site.
I think that's a good question. So, if I think it's important to know if the tumor is neuroendocrine or whether it's adenocarcinoma, which is a much worse type of tumor where you want to be more aggressive. If it's neuroendocrine at that size, you'd be better off with observation rather than doing a Whipple procedure, which is a really big operation that we do for these tumors when they're in that location. So, and I hope you're not booked for an octreotide scan. I hope you're booked for a DOTA PET scan because not too many places are doing octreoscan scan anymore. I imagine it's not even available. So that octreotide scans in that location, can help if it lights up, but there's also false positive uptake in that area of the pancreas right below there in the uncinate process. A lot of people have false uptake. So interpreting the test in this situation with a small tumor has to be done with caution. The best way to get this looked at and biopsied is to do an endoscopic ultrasound where they go down with a scope that has an ultrasound probe and they can kind of go through the wall of the duodenum and get some good samples of this tumor. They should be able to get that, and that will help prove whether it's neuroendocrine, and that'll be important to know whether to just observe it versus do something more aggressive. So it is kind of important.
Got it. Dr. Howe, I'm always interested in, lately I think we've all seen there's been quite a bit of activity in the NET space. Have there been things that have been developed recently, or what are the things that have been developed recently that have helped you perform your job better, would you say?
So surgical tools or medical tools? I guess you're talking about both.
I think both could apply. I mean, from your perspective specifically, I'd be interested in surgical tools, but I feel like my hunch is that more progress has been made in the medical tools. I might be wrong about that.
Yeah, so I would say the biggest thing is what we talked about earlier is that capecitabine temozolomide for pancreatic neuroendocrine tumors that are pretty advanced at presentation or with lots of liver mets. That is much more effective than any other treatments that I've seen as far as making tumors smaller so that we can actually take them out or do a good cytoreduction. So that's probably the most exciting thing that's come out in the last several years. As far as tools, I like to do microwave ablation. I think resecting plus ablating tumors has allowed us to preserve more normal liver tissue rather than doing big operations where we take out half the liver or 2/3 of the liver because there are 10 little tumors in there. That's what people used to do.
Mm-hmm.
And now we try to be targeting them where because we can do intraoperative ultrasound and kind of precisely ablate these lesions and then take some of the other ones out. So that's been really good. I think, I'm kind of excited medically about the recent approval of cabozantinib. We have a lot of patients with small bowel neuroendocrine tumors who are running out of options. They've had surgery, they've had PRRT, they're progressing again. And I think cabozantinib is a great addition to the armamentarium. Its efficacy might be better than everolimus, but it does have side effects. But that's been another recent addition just in the last year that's very exciting. As far as surgical tools, not a lot has changed, but what's exciting is that there are more and more surgeons around the country who know more and more about these tumors. So I think
Good point.
through groups like this and through NANETs, I think education has gone a lot further. So there are a lot more people who don't feel as intimidated by these tumors and are willing and able to do really better cancer surgeries.
Got it. Thank you so much. A few more minutes and a few more questions. Let's try to get to them. From Tara or Tara, please let me know if I'm pronouncing that correctly. That's important to me. Have you seen stable tumors and METs grow or become more aggressive after initial surgery or ablations? Essentially, can it wake the beast, so to speak? Currently, I'm on octreotide for watch and wait since initial diagnosis of grade 1 ileum NET.
Yeah, I mean, I haven't really seen that happen very often. I've seen maybe a few times.
Okay.
And, I think the tumors that you're more likely to see that in are people who have grade 3 tumors. And the biology of those is going to be more aggressive. And so you might go into the surgery thinking it's a grade 1 or grade 2 tumor, do your standard procedure, and then you find within a year or two it's kind of growing rapidly. And I don't know if it's really that you woke the beast or whether it was a grade 3 tumor. I think that's a circumstance that's it's more likely um, than waking the beast.
Got it. From Sasheen again, has it been proven that serotonin is the cause of CHD, carcinoma heart disease, and might Zermello be FDA approved for it soon? It seems like the heart trumps diarrhea, but I know it's all about the research and indications.
I think that's a great question, Shasheen. We think it's serotonin, and there are ongoing clinical trials looking at Zermello to prevent carcinoid heart disease. I think they're going to take a while to play out. So I don't think we know the answer yet, whether Zermello will help attenuate those effects. But it's a great question, and we have hope because that can reduce serotonin levels.
Question from Gail. I had debulking on the small bowel about 8 years ago, and now small tumors are on the liver and heart. Is PRRT a good choice or a good option at this time?
It could be.
Okay.
If if you've been on somatostatin analogs
Hmm.
and they're continuing to progress, then I think it is an excellent next step. If you haven't been on somatostatin analogs, I think you should be, and I would see what those do first. But you probably were on them and they progressed. So I think it is a good treatment. It depends too on the volume of disease. If you just have a few small spots, you might want to wait even longer. But if these tumors are many and if they're larger, like 1 or 2 centimeters or more, then it might be worth going with the PRT now. Sure.
Folks at home, if you're checking the comment thread, you can see that NCF is putting in links and resources to some of the things that we're talking about, trying to make it easier for you to find more information on those topics. So check those out, hit those links to get more information, and appreciate the team on the back end, always. Dr. Howe, kind of the flip side of the question I asked you a moment ago, instead of what recent developments, have got you excited, so to speak, where would you like to see more attention, time, money, development, etc., i.e., what are the gaps that you'd like to see filled in the next few years?
Well, I think the most important thing is to come up with better drug therapy for tumors because so many people have metastases and they would benefit from something that could be given in pill form or maybe by some kind of injection. So, and I think there's a lot of great work being done. The NetRF Foundation is helping to finance a lot of research looking at the basic biology of neuroendocrine tumors, and our lab is working on these things as well. And hopefully, we'll have understanding of new pathways that haven't been targeted, or maybe multiple agents that will work together in sync. But I think that's the biggest next place that we really need to go. I mean, surgery is surgery. We hasn't really changed that much. We got a few new tools, like I mentioned, but it's really finding a good drug therapy for metastatic disease. I'm also excited by the alpha therapy. I mean, I think that is exciting, and the preliminary data show that it may be more effective than the beta PRRT, but there are still concerns about whether it hurts the kidneys and or in even the bone marrow too in longer term studies. So those are the things that we don't know about, things that are in clinical trials. But I think new drugs is really where I think we're going to get the most bang for our buck down the road, and that's how maybe we'll be able to cure these things in a more directed way than we are now.
Got it. Appreciate you so much, folks. That is our shows today. I am off to Cartagena, Colombia for my wife's 40th birthday. Everybody say happy birthday, Maya. Appreciate you all being here. Dr. Howe, thank you so much for being back. We appreciate you as always. Tara says lots of great questions and another informative session, says Eileen. Always informative with you, Dr. Howe. I appreciate you being back.
All right. Thank you so much for having me. And thanks everybody for the great questions. shout out to all my patients out there and to everybody else. Keep well.
Absolutely. And thanks to you all at home. As always, we hope this program helped answer some of your questions. You can always reach out to the support line at ncf.net/support line. And otherwise, we will see you. We'll be back in 2 weeks on May 1st with another episode of Luncheon with the Experts. Finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time for Luncheon with the Experts. Stay healthy, stay safe, everyone.